Hello and welcome to a new episode of Majlis podcast by Emirates Hospital Group. I'm Wael Berro, family medicine consultant at Emirates Specialty, and today is a great honor to have Dr. Arun, our consultant neurologist.
Thank you. Hi, I'm Dr. Arun Sharma, and I'm based at Conrad Tower, Emirates Hospital Clinic. After obtaining my doctorate in neurology from a prestigious institution in India, I was privileged enough to enroll in a research program guided by Professor Ian McDonnell. Professor Ian McDonnell was the leading authority of MS in practically the latter half of all of last century. He was a mentor extraordinaire, and I was fortunate to have his tutelage. His diagnostic criteria, McDonnell's criteria, are still being used by academics and clinicians alike all over the world. Then I did a diploma in neuroelectrophysiology from University of Wisconsin, Madison, US. After that, I came here in 1997. So for past 28 years, I've been working here with many prestigious healthcare organizations, including Emirates Healthcare Group.
It's a privilege to have you at Emirates Group as well, and to work with you. And
Thank you.
There's no one else to talk to about MS, especially with this extensive experience you have with Professor McDonnell. So let's talk about MS. They call it the snowflake disease, but let's explain it. What is MS and multiple sclerosis, please?
Snowflake disease is a metaphorical allusion to a natural phenomenon that no two snowflakes are alike. And similarly, in multiple sclerosis, known by its acronym MS, is something like that. No two patients go through the similar journey or similar experience of MS. Everybody has ups and downs in MS, and this would be an opportune time to say a few words about MS. MS is an autoimmune disease of central nervous system that includes brain, spinal cord, and optic nerves. Central nervous system is a command and control system of entire body. Autoimmune means our own immune system strikes tissues because its programming has somehow gone awry. In MS, particularly in MS, there are some prior determinants. We call them risk factors. There's a trifecta of genetics and gender and geography. Females are more prone to nearly 2/3 of females are more prone than men. And geographically, farther you go away from equator, more are the chances of you developing MS. Then there are environmental factors, particularly now it's well established that prior exposure during your childhood or adolescence to Epstein-Barr virus, EBV, which causes infectious mononucleosis, and childhood obesity, low vitamin D level are risk factors. So same is smoking as for many other diseases. Brain has about 100 billion nerve cells, and out of which about 90 million nerve fibers go into spinal cord. So you can imagine the vastness of area which can be struck by MS. Now, the commonest form of MS is relapsing form, in which the course of MS is punctuated by attacks in which myelin is damaged of certain area. Now, coming to myelin is the nerve sheath of nerve fibers, just like plastic sheath of electrical wires. And if myelin is damaged, the conduction of impulses from brain to the spinal cord and to the peripheral nerves, which go to entire body, the conduction becomes slow, inefficient, and sometimes there is a complete transmission failure. MS occurs in its commonest type as relapsing variety. That means the course is punctuated by attacks and followed by some recovery to a variable extent and some residual deficits.
Thank you very much for this introduction and summary. So you've nicely kind of talked about MS, multiple sclerosis, and we know its various reasons, and we still don't fully understand it. But when it comes to symptoms, especially when you're talking about the relapsing type, we know that we have what we call the good days, we have the bad days. So if I were to ask you today to put yourself in the shoes of a patient, what would be, how would it feel like to live with MS, and what are the symptoms that we commonly encounter?
Living with MS is like a roller coaster ride. There are ups and downs from day to day, week to week, year to year, and a good day may begin with your brain firing on all cylinders, your body brimming with energy, there's spring in your walk, you breeze through your day with relative ease, and you go home, sleep like a baby. However, regrettably, such good days become few and far between as the time passes. Bad days, on the other hand, you wake up feeling overwhelmed with fatigue, you are unable to get out of bed, your brain is foggy, your body doesn't cooperate with you, and you have trouble accomplishing even the minutest task which you would do easily otherwise. And while you go to bed, you have cramps and you have body pains and insomnia. Now, coming to the symptoms, it depends on which part of MS, which part of central nervous system is affected by MS. In my experience, the commonest first debut symptom of MS is optic neuritis. That is inflammation of the optic nerve. And that causes unilateral visual loss. That's about 30 patients of first presentation of MS. And as per the statistics, about 70% of MS patients will at some point of time in their life will have a visual issue. So during bad days, you have more visual blurring, particularly in the eye, which was affected earlier. Secondly, sensory symptoms. So you have tingling, you have numbness, and you sometimes have balance issues because you are not receiving proper information from the ground while walking. Motor symptoms, like you can have weakness and clumsiness in one hand, you can have weakness and stiffness in one leg, or you can have weakness or stiffness in both the legs. And if you have cerebellar symptoms, which is like hindbrain, which is our control area for balance, you might have trouble walking, and you might be staggering all over the place, and you might be bumping into walls, and you might have a speech which sounds like scanning speech. I'll give you an example of Selma Blair, a very famous Hollywood actress, and she had to drop out of her career because of cerebellar signs. She could not speak her dialogues. And when you have these symptoms, which are hundreds of them, and you have a permutation or combination of these symptoms in any given individual, he would be unique in his own way. So his journey would be unique in his own way through MS, depending on how his MS progresses. And quite a bit of role is played in how fast you mitigate the inflammation, acute inflammation. And that decides how much recovery you're going to make.
But this brings me to the topic, and sorry here, because given the wide variety of symptoms, and it's quite difficult to diagnose MS, it could be B12 deficiency. Maybe some of the symptoms you're describing could be related to other conditions. So there's a lot of kind of overlap, and then eventually we start thinking of MS. Who are the people should come, and what do they expect? So let's say I'm suspecting I might have MS. Maybe I have someone in the family, maybe I don't. Like you said, there are some environmental factors that maybe have triggered it. When do I should, as a family doctor, but also more important, as a person sitting at home now listening to our podcast, saying, when should I start thinking MS? When should I go see my neurologist? And what are the tests that you will use to help you diagnose and confirm if I have MS or vitamin deficiency?
Thanks for this question. Very good question. Most patients, as I said, have some kind of alarming symptom. Sometimes they think of stroke. Sometimes they think of a vision issue because of some retinal problem. Some patients with optic nerve or visual issues go to ophthalmologist, and then when they look into the eye, they find inflammation of the optic nerve, and they refer to us. Other patients, sometimes they just ignore it because the disease is such, the acute attack passes off in a few weeks with or without treatment. But when they continue to have the residual symptoms, like they cannot walk properly, the hand remains clumsy, or they have continuous facial numbness, they present to some doctor. Could be family medicine doctor, could be a general practitioner, and they usually steer the patients to us. Now, as a neurologist, I would, of course, listen to the story of the patient first. A detailed history always helps. We've tried to see if there have been any such phenomena which had occurred in the past, whether they have any genetic history. And we do a thorough neurological examination, which is very important. So we find out if there are telltale signs of some kind of bad thing like MS. We proceed with MRI. MRI has some very particular diagnostic features for MS, and these days we have very high quality MRI scans available. Sometimes lumbar puncture is needed, sometimes not. That could also decide whether it's MS or not by certain findings in cerebrospinal fluid. We also now have included other things in MS criteria, which were there from Professor McDonald time. One was evoked potential. So we check let's say patient has only body symptoms like leg weakness, arm weakness. And if we found that there was a problem with the visual evoked potential, so that gives us an idea about dissemination space, a very fundamental criterion for diagnosing MS. Then there are other kinds of evoked potentials for spinal cord transmission of signals and auditory nerve evoked potentials, which tell us about brainstem transmission of signals. Then there is optical coherence tomography, which has also come up as a diagnostic criteria, which can tell us about retinal damage caused by optic nerve issues. So these are various clinical and paraclinical modalities which put together make us reasonably sure of making a diagnosis of MS.
Fair enough. So it is a journey, and it's not a black or white diagnosis, as in most conditions. And especially we know it's a chronic condition that takes time.
There's a considerable fluidity.
But that's where expert like yourself is actually the right person to consult. Now, I want to talk about treatment, but before I do that, I want to challenge you a bit, kind of get what I call removing your doctor's hat, and then talk about something personal, something from your journey, from your extensive experience, something you like to share that could be funny, could be something emotional that you've had from your years of experience. Anything you like to share with us today?
All right. Most patients living with MS live in an echo chamber of fear and anxiety engendered by social media, which is ubiquitous and omnipresent now. So I'm going to narrate a feel-good story. In year 2000, there was a 20-year-old girl, very talented, I would say prodigiously talented. She was doing international law at Oxford at that time. And she suddenly developed loss of vision in her left eye. Her parents brought her here and they sought my advice. MRI was done, other tests were done, and we could find out it was optic neuritis, which subsided, the visual loss recovered, optic neuritis subsided with intravenous high-dose steroids for 5 days. Patient was taken to Germany, a spinal tap was performed, and diagnosis of MS was confirmed. Now, back then, in year 2000, the only drug in the panoply of MS armamentarium was interferon, beta interferon. That young lady started beta interferon, and she suffered from some kind of allergy, fatigue, flu-like symptoms, and malaise, and she put up with it for about a year, and then she just dropped out of the treatment. Coming 10 years, until 2010, she was absolutely fine with healthy diets, Mediterranean diets, yoga, regular exercises, swimming, and avoidance of all kinds of, stressful triggers. She managed very well with lifestyle modification. In 2010, she suddenly developed weakness and numbness of left leg. Again, she was taken to Germany. And then she was put on a drug called 𝗠𝗷𝗹𝗶𝘀. And 𝗠𝗠𝗷𝗹𝗶𝘀 caused her swelling of the retina on the other eye. And she was devastated because it was a visual loss in other eye. And then she consulted an ophthalmologist. He said it's macular edema. It's not related to MS. And she was disenchanted with medical profession, with all kinds of medical drugs. And she, again, went to alternative medicine and started practicing holistic methods. 25 years later, fast forward to 2025, she is still okay with no disability, completely healthy, representing UAE as a diplomat in a country, in a foreign country. Whenever I meet her, I get impressed, and by her faith in God, by her optimism, by her effusive enthusiasm to live without drugs, and this is life. C'est la vie.
Absolutely. And thank you for sharing this. And at the end of the day, we know at the doctors, we have our limitations. We do what we can. And there are things we still don't understand.
Yes.
And I'm sure, and the most important thing, I'm glad she's well. And that's very, very nice to hear. Now, you mentioned in treatment, I'm going now to talk about treatment, if that's okay. And you mentioned the importance of lifestyle. You mentioned with this case, the kind of this lovely lady that she focused on healthy lifestyle, try to reduce stress. So I'm sure that's core part of the treatment plan. But what is about treatment? And you said 25 years ago we had only interferon. Things are moving very quickly. Are we nearing curing MS? Are we there? Do we still have a way to go? Where are we?
That's again a very nice question. Now, the working definition as it relates to, as it pertains to MS is, first of all, no relapses, no flare-ups, no further attacks. Secondly, no progression, no further accrual of disability. Thirdly, on MRI, no further shrinkage of brain and no new spots, which we call lesions, for 15 years. Now, all the innovative drugs which we have been around for nearly a decade. So we have to wait for 5 more years before we can define that cure has been achieved.
So I'll meet you here in 2030 and we ask you the same question
yes,
again.
Sure. And in past 1 decade, there has been a significant transformational paradigm shift from treating the acute attacks, mitigating the inflammation, and reducing the number of attacks, slowing down the progression, to cure. Now we are focusing on cure. So I'm going to rattle off a few names. Monoclonal antibodies, which are antibodies against antibodies. So we send in a hacker to treat the hacker who is
causing the problem.
So we have alemtuzumab, we have ofatumumab, you have ocrelizumab, and these monoclonal antibodies have been quite successful in past few years in meeting all these 4 criteria. Then we have another class of molecules called BTK inhibitors, which are again useful in reducing the shrinkage of the brain, which is very important. So far we have been focusing only on white matter lesions. Now we focus on gray matter issues as well. Then there is cellular therapy, stem cell transplantation, which is also being very successful in meeting all these 4 criteria. Then there is another form of cellular therapy being developed, which is called CAR-T cellular therapy. It's chimeric T-cell antigen therapy. So you send in, you take out the T-cell, you wash them out of all the bad antigens and send it back to fight the bad T-cells. So I would say that we are living in the most exciting time vis-a-vis the treatment of MS since the condition was first described by 𝗠𝗷𝗹𝗶𝘀 𝗪𝗁𝗀 in 1853. So 175 years later, we are able to find a cure of this disease. Second part of cure is preventing. Prevention is mother of cure.
Sure.
So now we know very well there is enough robust evidence that Epstein-Barr virus, EBV, which causes infectious mononucleosis, is the causative organism of MS. Exposure to this virus is mandatory to develop MS in later life. So accordingly, scientists are now developing a vaccine against EBV. Just like HPV vaccine was developed to prevent cervical cancer. Now this vaccine, just like MMR, if administered to infants, would most likely prevent development of MS in later life. Third part is recovery from the previous deficits. That might be helped by remyelination. That means repairing the myelin which has been damaged. One particular drug is now phase 3 trial. That is the ultimate stage for approval of any drug. So having crossed phase 1 and phase 2, there is a drug called 𝗪𝗃307 in pipeline, aptly called 𝗪𝗃307, which is supposed to be quite helpful in repairing myelin sheath, and that might lead to restoration of transmission of signals and recovery of some of the residual damages. So we are getting there.
So that's really good to hear, because that's very promising, and I'm sure people who are listening to us today who have MS, it's definitely the future is very promising.
By the way, today is the MS Day, World MS Day.
Oh, perfect. Very good. So it's great to have you here. Thank you very much for this informative session. That was really lots of knowledge, and thank you for sharing it, Dr. Arun. Now, if I ask you to summarize or to give us a take-home message for our audience in 1 minute, what do you want to tell our audience today, please?
My message is one: MS is no longer a scary, a nihilistic disease. We have to brighten our outlook to MS. If you have visual loss, if you have any kind of unexpected, weird things going on in your body, sensation-wise, weakness-wise, do consult a neurologist. And there are very successful treatments available now. And they can not only treat, they can cure your MS. And MS is not strictly a genetic disease. People get frightened that if my mother has MS, would I have MS? It's not strictly genetic disease. Certain environmental modifications are definitely needed to cause MS.
Thank you very much, and thank you for listening. This brings our episode today of Al-Majlis podcast by Emirates Hospital Group to an end. Please stay tuned for a new episode very soon. Thank you very much again, Dr. Arun.
Thank you, Dr. Wael. Thank you very much.